All right. So, but before I begin, I wanted to tell Dr. Ingram and Dr. Maxwell how much I enjoyed your session about encouraging preceptors to sign up. All the things that you identified are all the reasons why I teach, and you actually never know the impact of what you do sometimes until much, much later. And so, not to say that I'm like personally fully responsible for the following people. But for example, Dr. Shirley Shipper, who's our current Vice Dean of Education, was my student way back when. And Dr. Roshan Abraham, who's your communications lead and who leads foundations. He's a brilliant man. Was also my student. I taught him physical exam and history taking when he was a student. And so you never know. So I just love the collegiality. What I get out of it is that sense that I am making a difference and you folks will make a difference. So if you haven't signed up for teaching, honestly, it is the reason to live, really, to teach. Okay, so we'll get started. Thanks to Dr. Daniels again for kind of setting me up for talking about how to give and receive feedback in a small group and clinical teaching. I've already told you a little bit about myself. I don't have any disclosures or conflicts of interest. Okay, so this is what I'm hoping to achieve today. And I did present on feedback when I was here in June. I'm not sure how many of you were there for that. And if I see glazed eyes over, be like, oh, she's talking about it again. I hope that it's okay that it's a fairly similar talk. I had a moment of imposter syndrome this morning. And so I was like, am I missing something? Should there be more that I'm presenting than what I've already done? And so I actually went into Open Evidence, which is a great evidence-based AI for medicine. And I asked Open Evidence, I was like, can you give me a high-level overview for feedback in clinical medicine and clinical teaching? And so gave me this really beautiful high level overview and I read through it. I was like, phew, okay, I think I'm covering all the things I'm supposed to. So I apologize if you've heard this before. Hopefully it'll be some good review. All right, so our objectives are to define feedback, discuss the foundations of good feedback, which includes an environment, the learning plan, and direct observation. We're going to review pearls of feedback, and we'll review methods of providing good feedback using a framework, specifically for small group as well as clinical situations, and discuss barriers and pitfalls to providing and receiving feedback. And after this, I know I was given like an hour and a half. I have 8 cases which we can cover or not cover. We'll see how much time we have left and we'll see what the interest is for that. Now, in case you're wondering why I'm talking about both small group and clinical teaching, because I know that NAB has only launched into year 1, there is some clinical teaching for you in the form of LCE, but for both year 1 and next year, year 2. But come year 3, you're going to have clerkship students, and many of you are probably already teaching residents in your clinic. And so I always feel that clinical teaching is part of the feedback conversation. Okay, so what is feedback? So I've got a couple of definitions here. One definition is, descriptive information regarding a learner's performance in a given activity, information that's intended to guide future performances. And I've kind of highlighted to me what's important is in yellow. Telio says it's a dialogue occurring within a committed learning relationship that is used to create shared understanding of goals, performance, and standards, and a mutually agreed upon action plan. And so the idea of it guiding future performance is a very important piece on feedback. the idea that it's a dialogue and a relationship as precursors of feedback is important, and a mutually agreed upon action plan. All right. So when we use the term formative and summative, which, Dr. Daniels talked about today in assessment, formative assessment and summative assessment, the feedback is very similar. So formative feedback influences future learning and helps and focuses on the process. Summative feedback provides comments on past performance and often provides a grade. So we're going to spend most of our time in the formative feedback conversation. Okay, so unless you're a medical educator, your eyes may kind of gloss over when you see this. But this, and I notice Joanne smiling in the background there, but this is every medical educator's dream. And I think it's actually important to look at the learning cycle for a moment, because everything you teach has this in the background, whether we recognize it or not. So you're going to have identify the outcomes. So that's the learning objectives. So when you're teaching LCE, the medical students in your clinic, there are set learning objectives for them. When you have communication sessions, there are set learning objectives for that. And then the medical educator likes to plan the learning. How do you build that environment? What's the learning plan? And then there's the learn. What are the teaching strategies to achieve those learning objectives? And finally, you're assessing the students. You're saying, so did they learn what we wanted them to learn? And if they did or didn't, how do we tell them that they did or did not learn that learning objective? We give them feedback. And so regardless of what you teach, whether it's DL or PDG or communication or physical exam, this cycle is always in the background. Okay. All right. So we're going to talk about feedback specific to both small group and clinical or bedside teaching. Okay. So the foundations for good feedback requires a safe environment. So safe, respectful, positive learning environment. In medical education, we talk about, if a learner is feeling threatened in some way, they don't feel safe to speak their mind, they go into the fight or flight response. So they freeze. They go into what we call almost their reptilian brain. So when you're surviving, you can't learn. So if students feel threatened, they just stop learning. So how can you promote that safe environment? So you can have introductions. I talked about an icebreaker session today. If you've not met your students before, you can have an appropriate orientation, having teaching resources and handouts. Learners love having handouts, whether or not they read it, I'm not sure. But having a handout helps them recognize that you care about their learning. And then establishing a relationship. So if they know that their learning is in your best interest as well, then they trust that you will guide them accordingly. Okay. The hard part with feedback is that sometimes it can be perceived as criticism or failure. And we all know that we worked really hard to get into medical school. We've all done it, right? Do you remember when we were in medical school and we're thinking, oh, that preceptor is going to just think I'm so stupid. And I didn't want to admit I didn't know something. Like, how hard was that to say, I don't know? Right. And so thinking back to when I was a student, really helps inform what kind of environment I wish to put together. Okay, so the next piece of this is foundations for feedback is to develop a learning plan. Have a safe flight back. Take care. Is to develop a learning plan. And you're probably kind of going, oh my gosh, that sounds like a lot of work. So it does not need to be complex. Okay. And so if you have an LCE student in your practice, for example, it might be 2 minutes the first time you meet them. Okay. So for example, you pretty well have your learning plan baked into your small group teaching because you already have objectives. You're going to do an icebreaker. But like we talked about in communication sessions, you're going to review your objectives. You're going to go over the format. You're going to assign a timekeeper. That really sets up your learning plan. I often walk into, for example, my physical exam sessions. They'll be like, we're doing the neuro exam today, right? We're examining the knee and shoulder. Does that sound right? And everyone goes, yeah. I was like, okay, I'm in the right room then. And you can make a bit of a joke of it. You can also set those expectations. You can say things like, normally when I teach the shoulder, I like to demonstrate and then we'll all practice together. Does that sound okay? So you get permission, they know the lay of the land, and that's all it took was 10 seconds of an explanation. We do know that there is peer feedback in communications, and so clarifying that piece is important. So in the clinic, so who here works in Emerge? Okay. So quite a few of you. And do you have learners in your Merge? Okay. What do you do with your learners when they work with you? Because typically they only work maybe 1 or 2 shifts at a time, correct? Yeah. So what do you say to your learner when you get started? Yeah. Oh, can you use that so the folks online can use it?
So usually when I first met them, like for the LCE, they have their like 5 half days. So I
Yeah.
just clarify with them about how many hours is probably the equivalent to a half day. And then I give them the choice as to whether they want to do 1 half day or 2 half days or what they want to do for that shift because I work 24-hour shifts.
Okay.
And then yeah.
Wonderful.
Like just to get an idea so we're on the same page at the beginning. Because
yes.
I remember as a med student, if you don't know when you're leaving, that really sucks because you can't plan like when you're eating or driving. Like I'm not in Grand Prairie either.
Yeah.
So they have an hour
right
to drive home and there's weather and light and that kind of stuff.
Yeah, and I think so what you're really saying is that it's about setting expectations. And if we don't create that conversation, they may not. So you bring up a great point, right? You didn't know when you're leaving and when you're even allowed to eat and relieve yourself or any of those bodily functions that make us real people. And so that's why it's important for us as preceptors to open those conversations because the students won't. They're too intimidated. They won't admit to you that they're a real person who actually has real needs. So setting up those expectations are important. So reviewing gaps, expertise, skills. One of my friends who's an Emerge doc says to their learners, like, what's one thing you need to see today? Or what's one thing you would like me to observe you on? So you just pick one thing, and that might be all you need to do for setting up that learning. Now, if you are a clerkship preceptor or a resident preceptor where you've got somebody for 3 months, this conversation might be a bit longer, but it doesn't have to be. The key, though, is that you're setting expectations for regular feedback and you have a shared understanding of progress and competencies. Students won't tell you what they need. You have to open that conversation. Okay, so here's so Dr. Daniels, I think I planted him. We talked about direct observation, and the foundations for good feedback is exactly that, direct observation. So in small groups, that's pretty easy because you're in the room with them for physical exam, for history taking, for your integrated clinical reasoning, your DL. So honestly, direct observation there is really not an issue. And that the beauty is that you can give them timely feedback and adjust on the flow. However, It requires the safest environment. How intimidating is it to demonstrate a physical exam skill you've never done in front of three or four or five other people, including your preceptor? So that permissiveness to make mistakes and to be okay with it, to say, hey, we're all just learning, is an important piece of this part. Clinical environment for direct observation. So if you have a learner in clinic, it is very reasonable to set aside, you can't observe them all day long. However, you could set aside some time in your clinic to sit with them for portions of an encounter. And it doesn't have to be all of it. It could be the beginning or it could be the counseling part. It is important as like a learning, just so that you know, when you have a clerkship student, they have to have an observed history and physical. So, but again, it's pieces of it. And it's like a check mark. Sorry, I'm sorry, but it is a requirement. Joanne's going to smile right now. I think I talked about it last time. It's an accreditation standard. Yeah, sorry, not sorry, right? And I bring that up not because it's something that is supposed to be 100% across the board. So it is that important that they want the accreditors want to know that medical students are being supervised and they're not just being sent off to on their own devices, sort of thing. Okay, so especially in a busy clinic, it is best to plan your direct observations. Pick a time. Is it once a week, once a day? Is it first thing in the morning when everyone's not running behind yet? Pick a time for some direct observation. And this allows you to give objective feedback and timely feedback as well. Okay, so let's talk a little bit about pearls of feedback. Okay, so um, not all feedback needs to be given privately, but certainly constructive feedback is probably best behind closed doors and not in front of patients. Recognize that there's a huge emotionality to feedback, right? It's pretty easy to get defensive about it. It's pretty easy to get upset. Maybe people think, oh dear, I'm a failure. I'm no good at this. I'm going to flunk medical school. I'm never going to get into that anesthesia residency that I really wanted to get into. So recognize that even what we say may touch on some sore points that we don't know anything about. So sometimes, especially if you're going to give critical feedback, you can take your feedback and make it future oriented so that it more or less takes the sting out of it. You can use words like consider or try this for next time. You know, I noticed this. Maybe for next time you could try this instead. And that just immediately takes the sting out of the feedback. Also, provide regular feedback. Let's say, for example, I know none of you do this, but let's say, for example, there's a preceptor who never gives feedback, and all of a sudden you give feedback. What do you think is going on in the learner's mind? Oh no, I'm doing really bad because they never say anything. Yeah, exactly. I did something wrong. Okay, and I'm very guilty of this. I overteach. So do try to, provide only one or two areas for a feedback. So I have resident learners in my clinic, and we usually sit down at the end of the day, see part of normal, regular feedback. And I'll say, what's one thing you learned today that really stuck with you? And so we'll discuss that. I'll write a field note on that. That's part of assessment, formative assessment. And I tell the learners, look, if I wrote you a field note or we sat down and talked about one thing every day, think about how much you're going to know at the end of 1 year, right? So it's you don't have to do a lot, just one. Okay, so Feedback follows the SMART principles. I'm sure most of you know what that is. So I call it my SMART filter. So S for SMART stands for specific. So if you're going to give feedback, it should be specific. So your landmarking for a lumbar puncture was accurate. Your landmarking was great. So M, measurable. Something that you can measure, something it's kind of like specific. It's actionable. So it needs to be modifiable. If you're, let's say, if you're in the OR and I'm short and my preceptor's tall, my preceptor says, I just wish you weren't just so short. There's nothing that person can do. So if it's not modifiable, you just can't say anything about it. um, all right. So, and it needs to be relevant. So if it's not within the constraints of whatever it is you're trying to teach, it's probably not worth talking about. So just think, is my feedback helping with achieving the objectives of this rotation or this learning experience? And then timely. So I have seen this where a learner got something written about them and they're like, I have no idea what this is about. And it happened 2 weeks ago. And so it's really important that we see something. The best learning is to address it timely. If it's very busy, you can say, at the end of today, we need to talk about this, or we can circle back. Or sometimes if it's something that's quite critical to patient care, maybe you have to talk about it right away. All right. So there is no talk about giving feedback without talking about receiving feedback. And this kind of goes both ways. And so I call it the bidirectionality of feedback. It's not possible to teach without getting feedback on our teaching. It is also very interesting because I think our learners have a lot to say about how we teach as well. And sometimes they have very, very interesting and very awesome observations. And so I encourage us all, and this is tough, because I'll be the first to admit that I can get defensive about it, but to have that ability to just say, hey, I would love to get some feedback about my teaching and to do this and not defend myself because it's very easy to do. But getting feedback really helps us improve as well. I don't know if you knew this, but I teach the third year medical students just before they go into clerkship. I teach them about giving and receiving feedback too. And I had a very interesting conversation with the medical student. They're like, so do the preceptors know about this? And I was like, yes, I'll teach this from both sides of the view. All right. So when a learner is receiving feedback and when we're receiving feedback, I think of feedback as a gift, like that old Christmas sweater that somebody gave us at Christmas time. Like, what do we do with it? Do we wear it? Do we put it in the closet? Do we regift it the next year? So think of feedback as a gift. Just because they give you feedback doesn't mean you have to take it. Have a bit of that growth mindset. I'm sure we've all heard, Carol Dweck, who talked about this growth mindset versus fixed mindset. But the mindset of, growth mindset is this will help me grow and become a better preceptor. Whereas a fixed mindset, when you get feedback, is, oh, woe is me, I'm not very smart, I'm a failure, etc. I actually tell medical students that I think sometimes I go back and forth between growth and fixed mindset based on how I feel. If I'm feeling really kind of burned out and I'm tired and I'm stressed, I tend to kind of go into fixed mindset mode a little bit. And so sometimes I think as preceptors, we kind of have to know where our learners are at too. Because if they look like they're struggling, if they are coming in late, Maybe we need to ask them about their wellnesses first. All right. Okay, so feedback in small group settings. So we've talked a lot about this already. I talked about communication this morning, so I'm not going to talk about that now. Physical exam is a great way to demonstrate and sort of correct real time. And so you could say, hey, yeah, I noticed that your hand placement was here. Would you like to try here? And so you can give them real time placement so you can be specific. And I already talked about how psychological safety is ultra important when students are demonstrating. In PDG, or physician discussion group, or discovery learning, I actually encourage medical students to reflect as well. So encourage participation and self-reflection because they're actually still developing their physician identity. I give them feedback as a group unless I have concerns, because by and large, they're doing really well. Okay, so I'm going to talk a little bit about feedback frameworks. And some of these frameworks can be combined with clinical reasoning. You can probably use these all for clinical teaching, but I like to use Ask, Tell, Ask and Pendleton's for group situations. And I use 1 minute preceptor for one-on-one clinical teaching situations. Okay, so does anyone here use Ask, Tell, Ask? Yes? Anybody else? And you're probably doing it already. You just don't realize you're doing it because it's actually a very organic way of teaching. So Ask, Tell, Ask goes like this. The learner assesses themselves, and then you as a preceptor provides external feedback. And then the second ask is to check for understanding and develop an improvement plan. So it might look something like this. So how did that encounter go? Or how do you think your communication, your history taking went? And then you can tell them, yeah, I noticed that you did not ask about leg swelling in your pulmonary embolus case. And then ask. So based on feedback, you're going to ask that learner, how would you approach this differently? So ask, tell, ask. So the beauties of this, it's bi-directional. You're getting student self-assessment and it's SMART. So that specific, measurable, achievable or actionable, relevant or timely. Do not underestimate the power of student self-assessment. I have had it where I wanted to give students a very crucial piece of feedback, but I did not know how to say it tactfully. And so when I asked the student how'd it go, when they identify it, I was like, oh, thankfully they took my extra work out of my hands. And so it's a very, very powerful tool to use. Okay, so the Pendleton method is a version of ask, tell, ask. You ask what went well, and the learner responds. Then you ask what needs to be improved, and the learner responds. And you affirm and then provide some validating and or additional feedback. So it might look like this. Teacher says, so what went well? And the learner says, well, I thought I took an organized history. And you say, yeah, I agree. You definitely covered the pertinent points. What else could you do to improve? The learner might say, hey, yeah, I needed to ask more about risk factors for reflux the next time. Exactly. And the teacher says, yeah, exactly. Ask about reflux, but maybe make sure you cover, their lifestyle measures as well. So you can certainly teach in addition to that. So again, it's bi-directional. There's a student self-assessment and it follows SMART. Okay, so the one in preceptor is probably best for clinical teaching because it is a great clinical reasoning tool and it has tons of evidence that it works. And the beauty of the 1 minute preceptor is that it does save you time. It helps focus the learner. Does anyone here use 1 minute preceptor? Yeah, yeah. And many of you are probably doing it and not recognizing that's what you do. It was actually first described by a family physician in the late 90s. So, yay, us family medicine. Okay, so it's a teaching technique where the learner commits to a diagnosis and the supervisor elicits learners through a thought process while teaching to general rules. So it looks something like this. All right, so the teacher gets a commitment. So you get a short summary from the learner, a case presentation. And so you listen in and then you say it to the learner. So what was your diagnosis? And so the learner tells you, well, I think this was reflux. And then you could say, okay, so what supports your diagnosis? And so you can kind of see that clinical reasoning in there already. Yeah, it's behind the chest and it occurs after meals, and the patient wakes up in the middle of the night with retrosternal chest discomfort. And then you could reinforce what went well. Yes, you selected the appropriate management for your diagnosis. For example, yes, I agree that proton pump inhibitors is the appropriate management. But then you can correct mistakes. So, have you considered cardiovascular disease? What makes you think that chest pain is not cardiac? Did you ask about risk factors? So you can kind of see how this really elicits whether or not the learner knows what's going on. And then finally, you can teach to a general rule. So you might say, okay, so for this reflux, I agree that the proton pump inhibitor is the right way to go, but I would suggest that you always talk about lifestyle management as first line management. Okay, so you can kind of see how you can use this. You cover so much with these 4 or 5 questions. And again, it meets all that criteria for excellent feedback. Okay, so what are barriers to feedback? Well, who here wouldn't say that time, and time, right? Like, we all have busy lives, busy schedules, and sometimes, lack of time, lack of privacy is a huge barrier to feedback. Sometimes we think, well, maybe it's just this one time. I'm just going to let that go. So you may not give feedback on something. So now, if you're the giver of feedback, you might be like, oh, if I give this feedback, I'm going to hurt that learner's feelings. And I really like that learner. And I really want that learner to give me a good teaching score because, I really want to win that Teacher of the Year award. And I get crushed when I can't win that award. Like, I kid you not, these are the things that go through our heads. Well, okay, fine. It's gone through my head. And so, those are real thoughts. Or sometimes, we don't know what the learning objectives are. Or sometimes we don't know what to give feedback on. Okay. Now, as the receiver, it's a likable learner. Maybe they're early in their training. And so you're like, oh, they'll get better. I don't think I need to give them that feedback. Okay. So there's lots of things that prevent us from giving feedback to learners. Okay. There are also things that block the feedback message. So you're giving feedback. And sometimes the learner looks at you and you can kind of see it's just not settling in and you're kind of wondering why. So let's say, for example, I don't think anyone in this room would do this, but sometimes you're giving feedback on hearsay. A nurse or another colleague has said, this learner did this. And so you give them feedback on third-hand information. And the learner looks at you and be like, That wasn't me. Or they don't say anything and they walk away, but inside their heads, they're thinking, that wasn't me. And so if it feels untruthful or if it's not based on direct feedback, if that blocks the feedback message, sometimes you don't have a relationship. And so if you don't have that relationship, it's hard for them to trust you when you're giving them feedback. So, and that's why we talk about that using that non-triggering language as well. Okay, so does anyone here struggle to know what to give your learners feedback on? Anybody? Anybody? Okay. So, um, you know, bottom line is if you're not sure what to give them feedback on, remember you only need to give them one or two pointers. Think about why they're here working with you in the first place. So if they're working with you in LCE, it is largely an early experience. And so think about what those learning objectives are. Think about your learning cycle. And so I always break down clinical medicine into the knowledge, attitudes, professional behaviors, and skills. And so I'm sure there is something in there that you are able to give them feedback on. And if you're not sure, you can kind of say, hey, what was something you learned? And because we don't always know what their light bulb moments are. And so if they had a light bulb moment, you're like, oh, yeah. And then you're like, thank you for giving me that. And then on you go. Okay, so here's a summary. So if you are the giver of feedback or you're the educator, you want to set the learning environments and build a relationship. You want to label your feedback. Hi, I'm giving you feedback now. Okay, I know that sounds silly, but sometimes you really do have to do that. Give the learner an opportunity for self-assessment. Make sure that your feedback is smart. You want to give feedback on observable behaviors and give the right amount of feedback. Use non-emotive language such as try, consider, next time, and because. If you're wondering where the non-emotional language comes from, there's a medical educator in our at the Department of Family Medicine who analyzed all the field notes and was looking at what words came up the most, and these were the words that came up. And so it was a very interesting study about use of field notes. Be aware of barriers for providing feedback and also seek feedback. As a learner or the receiver of feedback, you're going to be working with the preceptor to develop learning plan and objectives. So I encourage learners to reach out to their preceptors, build a relationship, recognize when feedback is given, begin with self-assessment, have that growth mindset, think of feedback as a gift, and listen, express gratitude, and clarify. So I hope I've achieved these objectives of defining feedback and discussing the foundations of feedback. We revealed the feedback pearls. We talked about the methods of providing effective feedback, which include ask, tell, ask, Pendleton's 1-minute preceptor, and we discussed the barriers and pitfalls to providing and receiving treatment.